laparoscopic suturing and knotting tips and tricks. So, now you can see the slides. Before going for laparoscopic suturing, I want to tell you the basic stage of knot tying. There is three stages are there. One is tying the knot, that is called configuration, working or drawing the knot, that is called shaping, snuggling or locking the knot, that is called securing. So, configuration, shaping and securing. These are all the three stages. This is the saying that about the knotting, the knot is never nearly right. It is either exactly right or it is hopelessly wrong. So, we have to make a knot should be exactly right, particularly in laparoscopic surgery. So, the basic stage of knot tying, it involves two things. One is the under wrap, that means overwrap and under wrap. Overwrap means you are keeping your instrument over the thread and then you are making a wrap clockwise. So, that is overwrap. You are keeping the instrument below the thread, you are making a wrap anti-clockwise, that is called under wrap. So, coming to the anatomy of the thread, this is the anatomy. It has a tail, bite or functional portion and standing portion. Three portion is there: tail, bite and standing portion of the thread. The surgical knot must be safe and quick, easy to tie. Knots are categorized into two things: intracorporeal and extracorporeal. I am going to talk on intracorporeal. The intracorporeal knot is internal knot or laparoscopic, otherwise called laparoscopic knot. So, these are all the intracorporeal knot described. One is a square knot, ligature, double knot, Mayo knot and surgeon's knot. This is a square knot. A square knot is basically two opposite half knot. Once you suppose how it is opposite half knot, suppose you are making a wrap with clockwise and then another knot with the anti-clockwise. So, that means it is a two opposite knot, half knot, it ends with the square knot. Next is a ligature knot. Many surgeons think that this is the surgeon's knot. This is not a surgeon's knot. This is the initially double half knot and then single half knot. So, it is basically the ligature knot. This is called double knot, that means two double half knot. I could see many gynecologists are doing this type of knotting. They make a double knot first, again second also double knot. It is even though if it is a two double half knot, the knot withhold capacity is not like a surgeon's knot. This is a Mayo knot. Mayo knot is a two identical half knot. That means one overwrap, second knot is also overwrap, that ends with a granny knot, and then third one is the opposite half knot. So, two identical half knot, third is opposite half knot, that is called granny knot. So, the granny knot is a two identical half knot. It is it has a variable strength and unpredictable nature. Sometimes it slides, so it locks prematurely. It is not recommended for even in open or laparoscopic suturing. Finally, this is a surgeon's knot, otherwise called internal knot or laparoscopic knot. So, this is recommended for laparoscopic suturing. This is the standard knot for intracorporeal suturing what we practice, and holding forces increase with additional half knot. The surgeon's knot you can see here. So, it is an initial double half knot and then you have to make a square knot. So, it involves three knots, totally initial double half knot and then a single knot and then opposite single knot. So, it is basically three knot. So, it is a surgeon's knot. So, this will give a very good holding strength, and even in a monofilament this 3 is enough, no need for 4 and 5. So, when you want to have more knot, so I make a slide here, the more knot increase the amount of foreign material to the wound. So, suppose you are fixing the mesh, you want more foreign fibrous material, so you can make a multiple knot. So, even if you use a monofilament, 3 knot is enough with the surgeon's knot, or you can make it one more knot, 4 knot. And if you want to make 5 or 6, that means if you want more fibrosis, you can make a more knot. With this basic knowledge, I am going for laparoscopic suturing and knotting. With this slide, you can see laparoscopic suturing in the center depends on so many things: instrumentation, ergonomics, anti-coordination and imaging, but everything is there. If I just change the slide like this, that is a surgeon. So, if your surgeon is very good in laparoscopic suturing, so even with all these factors is not good, you can able to do suturing. So, that is why once you are master in suturing and you can do any difficult place you can able to suturing. So coming to the ergonomics, it is considered very important in laparoscopic suturing. One is manipulation angle, azimuth and elevation. So all these three angle, if you make it very perfect way, then your suturing is easier. So what is manipulation angle? So manipulation angle is between the two instruments. So two right side and left side of the camera, the instrument is there. Between the angle between these two instruments, it should be around 60° minimum or 70 maximum. It will give a maximum manipulation, comfortable way of manipulation. So the suturing also easier. Second is the angle between the azimuth angle between the telescope and the right hand instrument, or telescope with the left hand instrument. So it should be 30°. Elevation angle is angle between the instrument, no, working instrument and the tissue. Working instrument and the tissue, that means bowel or omentum, and the instrument angle, that also should be 30° or maximum 40°. So if you are making the port accordingly, keep the camera in the center on either side working, and then you are working in a distance around 15 to 20 centimeter distance, you will get a 60 to 70° manipulation angle. So why it is considered important manipulation angle? Because laparoscopic instrument has very limited degree of freedom, only 5° of freedom is there. So just I want to tell about the 5° of freedom here, because many surgeons they misunderstand what is the 5°. So 5° of freedom, first is in and out, you can take the instrument in, you can take it out. Second thing is a grasp, you can grasp the tissue or any other material. Third one is rotation, you can able to rotate the instrument. Fourth one is pitch, that is up and down movement, and sideway movement is yaw. So in and out, grasp, rotation, pitch and yaw. So this 5° of freedom is there with laparoscopy. With this 5° of freedom, and you have to make a comfortable way of suturing in almost all quadrant of the abdomen. So that's why this all these angle, ergonomics we are considered important one. And many people think that if it is robotic means easy way of suturing. And so do you think how much degree of extra degree of freedom in robotic instrument? So this is a robotic needle holder, it has only 7° of freedom, 2° of freedom is extra. In the sense, one is a wristed pitch and another one is a wristed yaw, only 2°. So what my thing is, if you make the angle perfectly, even if you put extra port, you can move to the other side of the patient, and then if you make the working area, suturing area, good angle and then comfortable way of standing, with this 2° of freedom is no need, even this 5° regular instrument, you can able to do any kind of suturing in laparoscopic surgery. So with this ergonomics, I am going for a needle. You have to select the type of the needle, and usually the needle bowl means it should be a less dramatic and round body and taper tip. Or if you want to fix the mesh, you can take a short and heavy needle. If you long needle, if you are handling laparoscopically, it most of the time it swivel and deflect when you are taking a bite. So it is not good for holding the long needle laparoscopically. 31 is a maximum or 37 is a maximum size. So you can make it very comfortable way. And this is the anatomy of the needle. You can see here, it has a tip and then a body, and then thread is attached in the body, back side of the body, and you can see this is a shoulder. So where the shoulder is, that is from the shoulder the tapering is started. If a round body means the taper between the tip and shoulder length is less. If it is a sharp, suppose you are suturing like a 1 echelon loop or to closer of the abdominal wall, that means it is a taper is more, the tip sharper is more. So for a round body bowel anastomosis, we should have a less taper. So that is also you have to see nowadays, because many companies are coming with the coming in the market, but it is not up to the standard one. And so the needle, it should be bronze or metallic finish, should not be shiny. And then so all the detail, taper and how much taper, so all these things we have to see, then only your suturing will be perfect. So this is it's called tip, hub and then arc of needle. So if it is arc of needle, you can see if it is half circle is better laparoscopically, little bit wider, so it will be holding strength will be more if we hold it in the center. Open needle holder we are taking here, it's a 2/3 1/3, but laparoscopically we are taking in the center of the needle with the tip of the needle holder. So that's why because you are handling the large long needle holder at 35 centimeter length, your hand is in one side, needle is in other side. So if you are selecting this type of needle in the center of the needle holder, center of the needle, if you catch the needle, then your suturing will be, your entrance bite and exit bite will be in your desired place. So now I am coming here, it is a crimping, just to have a knowledge about the how their thread is attaching to the needles. So it is a, they are making a small laser drill into the back side of the needle, and then they plug the thread, and then they are giving a crimping, crimping with the sufficient force, so that 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 metal is holding the thread. So here, if you are not giving more pressure, it will get damaged, again thread will come out. If you give less force, again thread will come out. So that's why another thing, if a point to be noted here is, you can see the thread size is, needle size is more than the thread size. So that means when you are doing anastomosis, particularly bile duct anastomosis, pancreatic duct or vascular anastomosis, and this will make the leak because the needle size is bigger than the thread size. Suppose you are using the heavy needle for the laparotomy, wound closer, defect closer, laparoscopic open technique, and you can see this is another swage suture. That means they are making a flattened of the back side of the needle, they are making it flattened, and then they keep the thread, and then they folded it like this. So that means cut section shows. So thread is here entirely circled by the this thing. Again, it is thread size is lesser than the needle size, and then this holding strength is more. Suppose you are going, suppose laparoscopically you want to do defect closer, you select a needle with this type of thread holding, then if thread will not come out from the needle. So even if you give maximum force. Needle again, it is a needle holder, 5 mm needle holder. What we are using laparoscopically, it is designed to hold 26 mm size of the needle. So routinely we are using 31. Nowadays we are using a V-lock suture, 37 centimeter, 37 mm, and I am using a 48 mm one loop polyamide nylon for defect closer. I have a small video, I will show it in this lecture. So even though it's designed for 26 mm, it is able to hold 48 mm. This is the ski needle, laparoscopically designed designed for laparoscopy, but we are not using it. We are using a regular half circle needle. You have to select the color as thread and length of the thread. Color black has a poor visibility. Don't select black color for laparoscopic suturing. Purple, white, and blue is good. And then length of the suture. And the standard teaching is 8 centimeter. I put for 10 centimeter here. For a first stitch or a single stitch 10 centimeter. Subsequent stitch you have to make it 2 centimeter. Suppose 4 stitch means 10 for first. Another 2 for another 3 sutures. So 16 centimeter you have to take. Coming to the memory tissue, thread has got good memory, difficult to handle laparoscopically. Example, Prolin, you can select the thread, less memory thread for laparoscopic suturing. So with this basic knowledge, I am going for a basic technique of suturing and knowledge, suturing, laparoscopic suturing, and for that we need 2 things. One thing, how to load the needle into the needle driver, and then how to align the needle into the needle driver. So for this demonstration, I select the endo trainer, and then you can see the 2 camera in the center. I keep on 2 side working instrument is there. So this is the left hand instrument, you can see double action jaw and a traumatic grasper. I am taking my left hand, this is the right hand, and you can see single action jaw, regular needle holder. It is an Indian company, make needle holder, and any needle holder is good, but only thing axial handle you have to select. And now you can see I am taking a thread. I am not holding the needle when you are taking a thread inside. You have to catch the thread close to the needle, then you can take through the trocar. So now the thread is inside, camera is there, or 2 working instrument is there. So now I am going for a loading the needle, how to load the needle into the needle driver. So now you can see, for that you can see here the needle is lying like this. This is the sorrow position of the needle, and you can see the fixed jaw. I keep it on the center of the needle, and then I press the tissue. When I pressing the tissue, the needle will elevate, that time I will catch. So concentrate here, concentrate only in the needle. Now you can see I am pressing it, you can see the needle is rotate, almost half circle rotation done, that time I will catch it. This is called deposit pickup technique. Now another thing, suppose needle, I drop the needle is like this. So this is a smiley position. Again the same thing, I keep the press the tissue, the needle will rotate, I will catch it. So this is one of the simplest way of loading the needle into the needle driver, that is called deposit pickup technique. And next one is called dangling pyruvate technique. Now you can see the needle tip is touching somewhere. When I move the thread, you can see I move the thread, the tip is in the same place, only the needle is moving up and down. This is called dangling pyruvate. Whichever position is comfort, I will catch the needle. So this is the dangling pivot. Third one is a two-handed technique. I catch the needle with the left hand, adjust the thread, and then I catch it with the right hand. So this is the two-handed technique. So this is the way we have to align the load the needle into the needle driver. One is the deposit pickup, dangling pivot, and two-handed technique. Then how to know whether it is a right angle or not? You have to rotate the needle holder. Then only you can see whether it is right angle or not. So now this is not a right angle. I am touching the tissue. Now you can see the needle get turned. Now you can concentrate here. By touching the tissue, the needle is getting turned. That is called brushing. Now you can see the needle is not good direction, and now you can see by pulling the thread, you can see the needle direction is getting changed. So now the needle direction is changed. So that is called by pulling the thread. I am doing it once again. You can see I hold the thread. You can see I am holding the thread. Concentrate here. The needle you can see it is getting turned. So by this way you can turn the needle, align the needle direction. Another thing is by the instrument. You can do by touching the instrument, I change the needle direction. But during this time you have to catch the needle in a gentle grip. Should not be in a tight grip. And another one, after aligning, how to hold the needle. No, the needle should be in the center of the needle, and the tip of the needle holder. You can see this is the way we do for open surgery. 2/3, 1/3. What 2/3, 1/3 distance I am catching, that is for open surgery. Laparoscopically, the recommendation is you have to catch the needle in the center of the needle with the tip of the needle holder. You can see I am catching in the center of the needle, and then you can see the tip of the needle holder. So this is what I used to catch, and then if you are catching like this, you can see it is not in the center of the needle, tip of the needle holder, it is the edge of the needle holder. That is wrong. Your needle holder life will be damaged. Another one, your exit bite should not be at your desired place. And these are all the things you have to practice in endotrainer, how to hold in a gentle grip, how to adjust the needle, how to adjust the thread, and how to hold it in the tip of the needle. Everything you can practice in endotrainer. It will come with if you practice regularly. And now I am showing here. I want to rotate the needle. You can see I am holding it here. So you can see I am rotating. Now you can see I am rotating clockwise. You can see 360 rotation. I can able to do it, but the needle I am catching it. Now you can see I am doing it in a anti-clockwise manner. So again the needle tip same way. So the 360-degree rotation is possible. These are all things you can make it in an endotrainer. Then only needle alignment, everything will be possible. So with this basic knowledge, I am going for a square knot. This is the commonest knot. So I am taking a stitch. You can see I am always any wound is there. Take a two-stage needle passage. I'm not taking an entire both side wound in a single stage. I'm taking a two-stage needle passage. Now you can see the tail end is in the right side. That is a needle holder side. I catch the long thread with the needle holder, and then I make a C loop. And this is the C loop. So once you make a C loop, keep the left hand instrument over the C loop, and then I'm making a wrap. That is called over wrap. Then I catch the tail end, and then I pull the knot out. So now what happened? The tail has come to the my left hand side. So I am catch the long thread with the left hand. I am making a reverse C loop, and I am keeping my right hand under the reverse C loop, and then I am making a wrap. Can you see here? It is a square knot. Okay, so one is C loop over wrap, another is reverse C loop under wrap. It ends with the square knot. So I'm showing another technique. Suppose if a knot is loose, here it is a suture is loose here. First knot is not fully tight. So to tighten the first knot, introduce the instrument below into the second knot, and then pull the thread. Now you can see the first knot is getting tightened, and then pull the thread out. The second knot is also getting tightened. So this is a simple way. Then another thing you can make, like now you can see I'm making a knot, so subsequent knot like this after making a square knot. So gem knotting method, as you imagine we are making a square knot. After making a square knot, you can see if you want to tighten the knot, you have to catch thread on both sides equal distance. And then I am taking the long thread, standing portion of the thread, I am bringing the thread close to the bite area, natural loop is formed. Again you can say I bring the thread close to the bite area, again natural loop, this time forming below the level of bite area. I am going to take clockwise. Again I bring, automatically it goes up, so I am taking anti-clockwise. Again it is coming, I am taking clockwise. So in this way, one time clockwise, one time anti-clockwise, you can make it a multiple knot in a shorter time. This also ends with square knot. This is what we practice in gym. After making a square knot, so multiple knot, you can use this technique. So this is the technique uh, I used in ELSA meet, that is an Endoscopic Laparoscopic Society of Asia meet in Hong Kong in 2005. There is a competition, 3 minutes. How many knots you have to make it in 3 minutes? There is a competition. So I made the board shows only 18 or 19 knots maximum. I aim for 30 knots for 3 minutes. I could able to finish 29 knots. So I got a first prize in that competition, knotting competition. But in that case I used only this type of knotting so that I can able to make 29 knot in a 3 minutes duration. And what are the mistakes? No, initially wrong method mistake I could see. Surgeons are in the initial phase, they are making a knot. So after making a wrap, you have to catch the tail end. But see, you can see, no, they think that long thread means the looping knotting is wrapping is easier. They're making a knotting somewhere, no, wrap somewhere, and then when you are coming down, see, they're keeping like this. Where when they are coming to searching the tail end, the knot get displaced. This is the wrong technique they are making it. So it is not, should not be, that's not good. So once you are making a wrap, after that you have to catch the tail end. So bring the thread close to the tail end. You can see after making a wrap, I will catch the tail end. Okay, so this is the way we have to make it. Instead of making the wrap in somewhere else, bring the tail end close to the, bring the long thread close to the tail end and then make a wrap. And then this is the another one, they are trying to make, pull the thread like this, and then they are making a wrap knot like this. What happen if you make a knot like this, both the thread is coming, and you can see here, both your instrument is hiding the tail end. They are searching for tail end. When they are searching time, the knot will get no, the thread will knot will come out from the instrument, then you cannot make a knot. So this is also not a good technique. So what you do, bring the long thread close to the tail end, the natural loop get formed, and then you can make a knot. You have to make the loop below the bite area or above the bite area, not on superior side or the lateral side. So going for a continuous suture, and imagine I am taking a, after making a square knot, I am taking a continuous suture. Always take a 2-stage needle passage, and imagine this is the finishing knot of continuous suture that I am going to finish here. That means you can see I am locking, I tighten the previous one, and then I am locking the thread. After locking the thread, I am taking another bite, I am going to show the Aberdeen's knot. I am going to another thread. So before pulling the thread, you can see I form a loop, I go through the loop, and then another loop is formed. Again I go through the loop, I pull the thread out. This is the same technique what we are using in a laparotomy facial closure. We are making a multiple time, here only 2 times. So this ends with a strong knot, that is called Aberdeen's knot. So this is one of the finishing knot of the continuous suture is Aberdeen's. Another one is there, that is a 3-leg tie, the name is 3-leg tie, that is also we are using in open technique. Same way, you can see, suppose imagine this is the last knot, I want to finish it here. You can see 3 leg is there, 1, 2 and 3, and then I have to make a knot with proximal leg. I am knot with the proximal leg, so that a knot will get tightened. So these are all the things routinely we are using it, but only they coined the name 3-leg tie. So these are all the easy method of finishing knot of continuous suture. The starting knot will be square knot, finishing knot will be Aberdeen's knot or a 3-leg tie. So everybody is find difficult in closure of the defect closure in IPOM surgery, and so this is one of the unedited video. You can see here already sac is excised. I am going to start a defect closure here. You can see here I am going to take a thread by puncturing in the lower edge of the wound. I make a small nick with a knife, only skin alone, and then through the nick I take the needle, 48 mm needle, 1 loop ethylon, and then all the thread is outside. Whenever I want, I take it inside, and you can see I am taking a bite. I am taking a stitch on the left side of the defect, and then I am taking on the right side of the defect. So now I catch the thread. Again I am taking a left side, and then the thread is not there. I am going to adjust the thread. See, I am adjusting it like this. Again I catch the needle, and then I take a stitch. So you can observe here I am using with the single hand. I am hold the needle, taking a bite, everything I am doing with my right hand. My left hand instrument I am not using. My left hand is on the abdominal wall. You can see abdominal wall is getting pressed, that is by my left hand. So by with the abdominal wall, now you can see the needle get tamed. I catch it with my single hand. I am taking another bite on the left side. Now again I am adjusting the thread. So this is the unedited video. Just I want to show you this only. It will take 10 minutes if you learn the suture. Now you can say I turn the needle. I am taking another bite. So again I am going to take a stitch on the left edge of the defect. Again right edge. So this is what we can make it. So now when you are coming close to the upper side, what happen, you can see the angle, no, angle will be difficult, and only the vertical stitch is possible, not the transverse stitch. So now I am aiming for transverse stitch. You can see I hold the needle in a, not in a right angle. So now I am holding in a right angle. After touching the tissue, you can concentrate here. I turn the needle direction. See, I turn the needle direction, and then I am taking. So I am trying to take it in a single handedly. Again it got slipped. Again I am not using with my left hand. I turn, see, needle get turned. Again I am touching the tissue, and then I am turning the needle, and then I am taking a bite. Now you can appreciate it is a transverse stitch. I can able to take it. So this is what you have to practice, during surgery. So within 4-5 cases, I think I tell you, you can able to do it in a better way. And then is no need to use your left hand. If you are using a left hand, your suturing time will be more. If you are using one is try to learn, do it from a single handedly, learn from single handedly, then your suturing time will be less. So I am now adjusting the thread. Now only you can see my left hand instrument is coming by pulling the thread. This time I keep the pressure little low, around 8 millimeter mercury, and then you observe the transfer stitch. No, always transfer stitch, all the stitch. So that's what now we are doing it in open. The same way I could able to make it laparoscopically, because it comes with training. Because I am taking a large needle, so that a very big defect or thick tissue I can able to take a bite. You can appreciate the transfer suture. Each and every time you have to bite. Nowadays we have a locking V-lock suture. All companies are making absorbable, delayed absorbable and non-absorbable locking V-lock suture. That will be, now once you tighten it, it will hold. Now you can see I am holding with my left hand. I am not leaving the tension. This thread, this will hold the, this is the last stage. I reach the upper border. Then I am coming down to the lower border again. This time I am not taking very close, distant way. I am taking a stitch. This is the second layer of the closer of the second layer of closer, and then same entry, needle where it's entered in the same level. I take the thread, I pull it out, and then I tie the knot outside. So the knot will go to the subcutaneous or antecedent level. The entire defect is closed. So this is possible with the endotrainer practice. It looks only 10 minutes time or maximum 15 minutes for a defect closure. The same way mesh fixation, we are not using a taker in gem, only the large mesh 30-20 or 25-20 or some difficult case we use the mesh taker fixation. Otherwise we fix the mesh with suture. Now you can see I am taking a suture, and this is the one place. It is a entrance bite and exit bite, any level you can take. Even a thicker suture or thin suture is acceptable. Even if a knot is not tight, that is also acceptable, because our aim is to fix the mesh to the abdominal wall, that's all. So that's why this is a good place for learning the suturing. So usually my residents, we are teaching, giving a first chance of suturing, in the experience with only the fixation of the mesh, because the bite may be thick or thin, wide or short, knot may be tight or loose, anything is acceptable here. So this is one of the good place to learn the laparoscopic suturing. So some of the advanced suturing technique also is required in most of the surgery technique. So what is advanced? Now here the tip and tap mesh fixation, many surgeons they are using only the taker. If you use a taker 20 numbers, now we are using only 3 or 4, and then if they are giving a steroid sterilization or ETO sterilization, it is not 100% sterile. Even the steroid or ETO will not go through the tube till the taker, it won't make it sterile. But anyway, it is not basically it is not recommended. And here in gem we are fixing the mesh with the suture. Now you can see this bilateral tip. I keep the mesh. Usually my practice is about 17 by 12 or 18 by 12 centimeter mesh. I kept the mesh. You can appreciate here. I'm going to take it on the Cooper's ligament. You can see when I take the Cooper's on left side, I'm not holding the needle in a right angle. You can see the needle is in a oblique angle. I'm taking a Cooper stitch. Now you can see without any struggle, no, I could able to take. That means that is a Cooper's ligament. If a struggle means that is a periosteum. So now I'm making a knot, and you can see I make a knot no clockwise. Now I'm making anti-clockwise. So it ends with the square knot. And suppose you want more fibrosis, you can make a more knot. So usually 5 knot we used to keep it, that is no fibrosis we require. Now I turn the needle by holding the thread, and then I am taking a stitch on the right side Cooper's ligament. So here why it's I comes in advanced suturing technique, because this is the vertical suture. Sorry, I am not taking a horizontally in the base, it is a vertical suture. Like after TLH wall closure is also comes in advanced suturing technique. So this is the desufflation. So I fix the mesh with the Cooper's ligament. Another situation is called divarication or diastasis recti, and you can see here this is a more than 15 centimeter divarication, and you can see inside, and you can see very long distance. Again I am taking a lower edge of the divarication, I am taking the needle, and that is the 48 needle with the loop ethylon. I am taking a stitch, and you can see all the stitch I am planning for a transverse horizontal way. I am taking from left side to right side. Now I am turn the needle, I am going to right side to left side in a graded manner. No, I am not taking a both edge of the divarication. I am taking starting from left side. I am taking 1 centimeter length of the linea alba, again with 1 centimeter gap. I am taking another stitch on the linea alba in the same line, again another stitch in the 1 centimeter distance. So I reach the left side, right side. Again I turn the needle, again I am taking a stitch, again with the centimeter gap I am taking another stitch. So like this I take a stitch like a plication stitch in a zigzag manner, so that now you can say I have adjusted the thread. So everything I am doing with a single handedly, you can observe here. Now you can see just I am going a little backward. You can see I am adjusting the thread, now you can see needle get turned because the thread is in the abdominal wall. So with this support now I am turning the needle by touching the abdominal wall. Left hand is there in the abdominal wall to help me. Again I am taking the thinned out linea alba, I am not taking a muscle. Again you can see all the suture is in a horizontal line with the interrupt with the gap in between. Now you can appreciate it is a zigzag manner I am take, and each bite 1 centimeter gap, each row of suture 1 centimeter gap. So this I made it with the single handedly, and now the thread now I am going to tighten the thread. During the time of taking a suture, I keep around 14 mercury pressure, and then when tightening the suture thread, I am keeping 8 millimeter of mercury. So what happens when you tighten like this, the thinned out linea is become a vertical fold and then is coming together. That's why this technique is described by Palnivelu sir, and then we are practicing in gym. And we coined the name a Venetian blinds technique. Venetian blinds, in the windows we are making it, it's like a wide window covering cloth, and then when you tighten it, it is all the layers become turn vertically and then coming closer the same way. Now you can appreciate here, and partly it was done, and with the 14 pressure you can see it is bulging out with the trans illumination is there. Here there is no bulge because it's already plicated. So again I'm turning the needle, and then I'm taking the upper side. So like this I'll take a suture, and then once you close it, tighten the suture, it will become a vertical fold and then comes closer. It's around 2 to 3 centimeter. This will bring the rectus muscle on more medially. That means normalization of you can see this normalization of the rectus will be there, and after that we are uh, after that we will place the mesh, and then we fix the mesh with the laparoscopic suturing, and with this will ends the procedure. So it's a plication like this, and then mesh fixation. So this will not recur if you are not plicating. Keep the mesh, it will recur. Even if you so any number of suture or any number of tack, it will recur. If you plicate the divarication and then keep the mesh, so recurrence will not be there. Sometimes you may take a reverse bite, and you can see I am taking a suture After that, I want to go to the horizontal mattress suture. You can see I turn the needle. I am taking a reverse side from left side to right side. I am going now. So here it will happen. No, it comes. You can see the fundoplication is in fundoplication. I take the anterior wall esophagus. I turn the needle. Again I am take the posterior wall of the fundus. I am going to the again I am going to take anterior wall of fundus, and then this is the stitch, otherwise called a mattress stitch or U stitch. This will hold the fundus to fundus in a good way. So the reverse stitching is required in most of the places. One example is the fundoplication. Another example already I told in a divarication of recti. So sometimes you required suturing in the left hand also. So that's why the suturing in the left hand I used to call dominant hand, and you can see this here. I'm taking a stitch on the left side, and then I'm using my left hand. I'm not changing the left hand needle holder, because most of the time we are handling the bowel or tissue. Left hand, any forceps is enough, bowel holding or a Maryland is enough. And I'll tell a situation. You can see this is the extended gastrectomy. So total gastrectomy, extended total gastrectomy, I extended around 2 to 3 centimeter length of the esophagus, and then I'm firing, I'm anastomosing the esophagus and the jejunum. Extended total gastrectomy, esophagus and jejunal anastomosis is being done with the stapler, and then after firing a stapler, you can see jejunum is attached to the esophagus, this entry to be closed, and then now I am taking one stage suture on the right side of the staple entry. Now I am taking a thread, I am going on the left side of the staple entry, and then I am taking a stitch on the esophagus. You can see the, now you can see if I use the right hand, even in the reverse stitch I cannot able to take it, the angle is not there. Otherwise I have to pull this bowel to this side, then only I can able to take. If you pull means the anastomotic line will get disturbed. So what I did, I take it on the my left hand I used to take a stitch. So the right esophagus is perpendicular to my right side, right hand. So again I am making a double half knot, C loop, and then reverse C loop, under wrap. So now I am taking a esophagus is perpendicular to my right hand, jejunum is perpendicular to my left hand. So I am taking a stitch on the left hand, and you can see my perfect way I am taking, and you can see very minimal pressure is required if it is in a right angle to the tissue. Again I am taking stitch on the left hand. So in many places, and no need for changing the needle holder on the left hand. Even with this regular instrument, we can able to take a stitch on the left hand. So now again esophagus side I am taking on the right hand, jejunal side I am taking on the left hand. So I am not feeling any discomfort. So these are all the things you have to practice in endotrainer, and that will help during your surgery time. So now I am taking esophagus, again anterior wall. So now I have to, this is again jejunum on the left side. So now I have to, after this I have to take the posterior wall of the esophagus. So now the posterior wall, the angle is not not good. So I turn the needle, and then I give it to my left hand, and then I am taking a stitch on the left hand using the left hand using for a esophagus side. Now jejunum is perpendicular, so I am taking a right hand for a jejunum. So I use if you see this video, I alternatively use my left hand and right hand according to the direction of the tissue. I am not pulling the tissue according to the direction of the needle. So that's what I want to tell you. According to the tissue, you can change the needle. Don't change the tissue according to your direction of the needle. Only thing, for abdominal wall, you can change the abdominal wall direction according to your needle. For bowel anastomosis, you can change the needle direction according to the bowel. So this was done, and I checked the leak test also. There is no air bubbles. So this is what we can do it on the left side suturing. So when you are suturing, there is a left hand instrument to be hold it in a different way. So this is what everybody's are holding. All the instrument is placed on the this place in the right place. That is, if you do like this, what happen? You can see here my wrist is flexed, and then forearm is supinated. When I making a knot or bite, you can see automatically my body I bend to the left side to accommodate the knotting. So that is not good. So I used to hold like this. You can see only with the middle finger in the ring, and then index finger I rotate like this, I hold like this, so that forward and backward movement, rotation, everything easier. Now you can see inside PIP, and I am rotating like this, very comfortable way. You can see, making, knotting, everything is easier, and I am not turn, I just stand very comfortably, I am not moving to one side. So again, suturing is very better. So this is the way I used to hold the left hand. This is the wrong method. Most of the surgeons are doing like this. This is the wrong method. So this is the right method. I'm doing like this. If you hold this like this, your suturing will be easier, knotting will be easier. So how to master in suture? You have to make three things. If you are doing the three things, you will be master in suturing. The first thing is practice in endotrainer. Second thing is again practicing in endotrainer. Third thing is again practice. So you have to practice in endotrainer. Then you will be master in suturing. So 1 hour daily practice in endotrainer for 1 hour a day, and within a month, 30 hours. Now within a month, you will be able to make any kind of suturing. There is a stages of mastery, not only in suturing, in any skill, laparoscopic surgery or any skill, it can be applicable. That is a stages of mastery. One is unconscious incompetence, that is you are unaware of your skill, that means you are in a PG period, you are unaware of your skill. Then conscious incompetence, you are aware of your skill but you need some improvement, then you have to go for some training or some under supervision, you have to do that, you have to perform that procedure. And then third one is a conscious competence, that is you have learned some basic skill but require a lot of effort to implement them. Yes, you have to make that effect with the basic training in endotrainer or something. You have to put a lot of effort to make it a better way. And then final one is unconscious competence, that is you have assimilated skill and apply them automatically. Without your knowledge, your hand will do no changing the needle direction or changing the needle to right and left hand. That will come, no, you are not planning before, but according to the situation, no, your no, automatically your hands and mind is getting applied. So that is called unconscious competence. So everyone should have this unconscious competence level, then only your suturing or laparoscopic skill will be better. Thank you so much.